BSI, is my scene safe? My mechanism of injury is a patient who fell from one flight of stairs. Additional units, I'm going to consider them, but at this point I don't see them necessary. Being that the patient fell, I'm going to immediately have my partner maintain inline spinal immobilization. I'm going to walk up to the patient. The patient does not appear to be responsive at this point in time. I'm going to check his responsiveness. Sir, are you okay, sir? He's not responding to verbal stimuli at this point. I'm going to give him a sternal rub. Sir, are you okay? He's still not responsive. We're going to check a carotid pulse. He does have a pulse. My main concern at this point is his airway. We're going to open his airway utilizing a jaw thrust maneuver. We're going to insert an adjunct. We're going to insert an OPA, and we're going to begin BVM in this patient. We will be breathing for him at a rate of 12 to 20 per minute. We will have oxygen hooked up to our BVM. He is now breathing via us. I'm going to begin checking his circulation. Does he have radial pulses? He does have rapid, weak pulse. At this point, we're going to look at his skin. He is cold pill and diaphoretic, showing signs of shock. We're going to initiate shock management. We do have oxygen on this patient, and we're going to cover him. He is going to be a rapid transport patient, seeing as he is unresponsive and we are maintaining the airway. I'm going to have my partner obtain a set of vitals. I want a blood glucose as well. While my partner is doing that, I'm going to try for a large bore IV, a 16 or 18 gauge, preferably in the AC. Is there anyone on scene who can give me a sample history? If not, at this point, after IV is established, we are going to log roll the patient on the heads count to maintain that spinal immobilization. So we're going to go on the heads count. 1, 2, 3. At this point, instead of moving the patient more than necessary, we're going to palpate the back. We are looking for any abnormalities or deformities. I do not note any abnormalities or deformities or major bleeds at this point. We are going to roll the patient back onto a long board and secure the patient for rapid transport. Now we're in the ambulance. We're going to move on to our secondary assessment. We're going to start at the head and work to the toes. We are at the head, we are palpating, we are touching, looking for any abnormalities or deformities. I'm going to check his ears for fluid. I'm going to check his nose for fluid. I don't note any fluid. We're going to move down to the neck. The problem is the patient already has a C-collar on. So it's hard to tell the position of the trachea and to note any JVD, which would be an indicator of a cardiac issue. We're going to move to the chest. We're going to expose the patient's chest, looking for any paradoxal movement. We're going to palpate for stabilization. This patient's chest is stable at this point. I also want to listen. Even though we're bagging them, I want to make sure the patient is moving good air. It appears the patient is moving good air. So we're going to move to the abdomen. We're going to palpate all 4 quadrants. Then the pelvis, we're going to check the stabilization of the pelvis by pushing in and down. We're going to check the lower extremities, looking for the same DCAP, BTLS, any contusions, any bleeding, any hematomas, any tears, lacerations, abrasions. None are noted at this point, but we are going to check for pedal pulses. Typically, it would be the CSMs, but seeing as the patient is unresponsive, he's not going to have very much sensory. Pedal pulses are present. We're going to move to the upper extremities or the arms, and we're checking for the same thing. Good radial pulse. At this point, we're going to manage any secondary injuries that we find. We're going to reassess this patient every 5 minutes. He is a critical patient because he is unresponsive and unable to maintain his own airway.